Well, it feels like I went from the stove into the freezer, although it's not really that hot in California. It's just not as cold as it is here. Imagine getting up at 5 in the morning and talking to a bunch of people about COPD. That's kind of what I'm doing right now because I'm still at 5 o'clock in the morning. But it kind of reminds me a little bit of the hypertension guidelines of what my professors used to tell me in medical school, which is, we're teaching you 50% of what we're telling you is wrong. We just don't know what 50% it was. And they seem to say this with a glee, and I didn't really understand it. But I guess for our lifelong learners, those of us who are lifelong learners, we realize that we'll never be put out of business, right? We're always going to be able to refine what we're talking about. What I want to talk to you about today is the state-of-the-art of the treatment of COPD. So let's get started a little bit with where we're going to go. What we're looking at here, just up the street from where I practice, is a place called Highland Springs Resort. It's been there for many, many years. In fact, this is where Einstein used to go to retire to after he had a long stint at Caltech way back in the 20s and 30s. And that tree is actually still there. It's about 1,100 years old. And people like to have weddings in front of it. I think that their wedding are going to last longer, potentially. In terms of the, here's another picture of a wedding out there. So if you're ever out in the Southern California area, look up Highland Springs Resort. It's a beautiful place, lots of lavender and things. All right, so let's talk about some questions. These are some pre-test questions, and if they don't make any sense to you, don't worry about it. By the end, I'm hoping to get 100% test on all of this, okay? So question number 1, all of the following are true except A, an FEV1 divided by FVC ratio of less than 0.7 defines the presence of COPD. B, the severity of COPD is determined by the FEV1% predicted. A Bode score of 10 predicts an 18% 4-year survival. Or D, an alpha-1 antitrypsin deficiency is seen in only males because it is X-linked. Or E, the majority of COPD is caused by smoking. All of those are true. One of them is not true. Which one is not true? It's kind of like election night here, right? With 25% precincts reporting. Looks like D is on its way to the governorship here. All right, so alpha-1 antitrypsin, we'll come back and circle around with that, okay? Question number 2, which of the following patients would benefit from supplemental oxygen? Is it A, a 55-year-old male with severe shortness of breath and an SpO2 of 92%? Or B, a 65-year-old female with a resting PaO2 of 58 millimeters of mercury and bilateral low extremity edema? Or is it C, a 75-year-old male with severe shortness of breath and a PaO2 of 58 millimeters of mercury? Or D, is it a 68-year-old female with resting SpO2 of 90%? Or finally, is it E, a 78-year-old male with severe shortness of breath and a resting SpO2 of 92% with lower extremity edema? In other words, you've got 5 people in your waiting room and you've got 1 oxygen tank in your office. Who are you going to give it to? Okay, a little bit of a smattering there. Let's keep going on. This one's a little bit simpler. Pulmonary rehabilitation is indicated for what type of patients with shortness of breath? Is it the gold stages 1 through 4, 2 through 4, 3 through 4, or is it just 4? So the gold stage guidelines stage all the way up to 4. I heard a question there about hypertension, why we only have 2 stages of hypertension. Gold criteria, gold stands for the Global Initiative for Obstructive Lung Disease. Rank it to 4. Okay, we'll talk about that one. My favorite question, number 4. What is the appropriate order to escalate therapy in severe COPD patients? And assume that patient is already on an albuterol inhaler or rescue inhaler. Is it A, LAMA, ICSI, LABA? B, ICSI, LABA, LAMA, C, LABA, ICSI, LAMA, D, LAMA, LABA, ICSI, or E, ICSI, LAMA, LABA. And for anyone just walking into the room right now, no, this is not a Klingon convention. A LAMA is a long-acting muscarinic antagonist, a LABA is a long-acting beta agonist, and a ICSI, I just made that up. No, it's an inhaled corticosteroid. So what is the order that we progress in? This has really become important in the last few years. Research is coming out showing that there is a particular order that you want to go through, and that has implications in terms of what inhalers you put patients on. So let's see here if you've made your choice. Okay, there's a definite predilection there. We'll go over that. And I think the last question, which patient would benefit from a PDE4 inhibitor? Okay, not a PDE5 inhibitor, but a PDE4 inhibitor. There are some giggles out there. PDE5 inhibitor is like Viagra, right? Okay, so this is a PDE4 inhibitor. Is it A, a 55-year-old male with an FEV1 of 20% of predicted and no serious exacerbations in the last 5 years? Or is it a 65-year-old female with FEV1 of 60% of predicted and a recent hospitalization 4 months ago? Or is it a 75-year-old male with an FEV1 of 45% of predicted and a recent hospital admission and flare 10 months ago? Or is it a 68-year-old female with an FEV1 of 40% and a flare of her COPD 2 years ago? Which one is going to benefit from the PDE4 inhibitor? There's 2 points there, and we will bring those out. Okay, there seems to be a battle between red and blue. That kind of summarizes the last 8 years in our country, right? Okay. So you know that this is a pretty important topic when I've got a guy from the 1500s up there, right? COPD, how art thou out of breath when thou hast breath to say to me that thou art out of breath? That's from Romeo and Juliet. Very, very pithy. So you guys know a lot of this already. COPD, as you know, is a common preventable disease. Symptoms of dyspnea, cough, sputum production. What are the risk factors? The biggest one is smoking, of course, but there's also occupational dust and chemicals, things that we're experiencing out there in California. Fortunately for this particular thing, whenever the Santa Ana winds come up, for those of you who have lived in Southern California, usually we have a onshore flow that goes from the ocean onto the land. So it's a westerly wind, right? But then these things called the Santa Anas come up where there's a huge reversal and you get this wind from the east that blows out to the ocean. And it kicks up a lot of dust. People have respiratory problems, and that's really when we get the fires. So fortunately, all the smoke goes out to Hawaii, sort of. And so we don't have to experience a lot of that smoke. And you can see satellite images of this, actually. If you just Google this, you'll see this smoke going right out into the ocean. So fortunately, we haven't had the major problems with that in the last couple of weeks. But chronic exposure to this type of pollution and air quality can cause problems. So you know this. And the two major things, and you may have remembered this from medical school, remember the pink puffer and the blue bloater. The pink puffers were the ones predominantly with emphysema. So these people were not necessarily hypoxic. They were not coughing up a lot of sputum, but they had horrible DLCOs. They had huge emphysema. They had flattened hemidiaphragms, okay? And that's the people here on the slide on the right to show that pathologically. They have bad emphysema. Versus the blue bloaters, who are hypoxic. They would be coughing up copious amounts of sputum. They had inflammation in the airways. They were in the hospital every other month for these flares, and that's the bronchitis and the obstruction. You rarely see those two extremes. Typically, you see both of those in patients, but that's kind of what you're seeing in these patients. So the sine qua non, the diagnostic criteria, the hallmark that's going to tell you if your patient definitely has COPD is this ratio of the FEV1 divided by the FVC ratio. And that's the core criteria for the GOLD guidelines. FEV1 divided by FVC of less than 0.7. Basically what it's saying there is that you cannot blow out more than 70% of the air that you can blow out in the first second. Okay, if you cannot blow out more than 70% of the air that you can blow out totally in that first second, you've got obstructive lung disease. And what you can see there on the slide is the red flow volume loop is the measure of flow, and you can see across the board it's going to be reduced. It's less And for some people, it takes 5, 6, 7 seconds to get all that air out. So how do we divide the severity of COPD? We don't look at just the FEV1 divided by the FCE ratio, but actually just the FEV1 itself. And the point that I want you to look here is, it can be a little confusing. You don't have to memorize all of these numbers. But the point is that gold stage 1, which is the most mild, 80 to 100%, and 2, 50 to 79%, is above the 50% mark. Okay? Whereas 3 and 4 is below the 50th percentile mark. So if you just remember that, 1 and 2 above 50%, 3 and 4 below 50%, that's going to be probably enough to get you through. Okay? And then we can fine tune it. So just remember, to make the diagnosis, you need the ratio. To determine severity, just the FEV1. And if it's above 50% of predicted, you're stage 1 and 2. If it's below 50%, it's 3 and 4. Okay? We know that looking at FEV1 over time, that if you quit smoking, you're going to lose FEV1 less quickly. Everybody loses FEV1 as they get older. And you can see there by the graph that, yes, when you were 25 years old, you really were the best that you were ever going to be in your life. And from there, it is all downhill. However, it's a much slower decline from 25 if you're not smoking. And so when they stop smoking, their rate of decline of FEV1 is more parallel to the person who is a never smoker. Which brings up another question, and that's your patients in the clinic. And we all have these patients, you know that, right? You ask them, have you stopped smoking? Well, implied in the answer is no, but they say, but doc, I've cut down. I'm not doing it. I'm down to 1 cigarette a day. What they're not telling you is that they're smoking that cigarette down to the last drop, okay? Which is, for somebody else, maybe just a regular smoking of 2 or 3. Well, the problem is that when we look at the intermittent quitters, which is in blue, they are very similar to the continuous smokers. Okay, so if you really want to get the benefit of preserving FEV1, you've got to be a sustained quitter in these situations. Which leads us to the vicious cycle. The vicious cycle of smoking causes dyspnea, cough from COPD, and because of that dyspnea, nobody likes dyspnea, so they stop doing things that cause dyspnea. It's classical conditioning, right? And when they stop doing those things that cause dyspnea, their muscles are not used, they become disused, and you get deconditioning. And guess what? Deconditioning causes more carbon dioxide to be produced, which causes more dyspnea. And so you have this vicious cycle of disuse from hypoxia, and hypercapnia causes deconditioning, which causes more hypercapnia. And you get people slowly and sometimes rapidly declining in the amount of stuff that they can actually do. We'll talk more about how we reverse that. Once again, I'm going to highlight the FEV1% predicted. 1 and 2, greater than 50%. 3 and 4, less than 50%. So what's new this year in the GOLD criteria, you may see like they have stages 1, 2, 3, and 4, or A, B, C, and D. And what they've done is they've really tried to make this as complicated as possible so that you actually do have to send the patient to the pulmonologist to understand what's going on. But let me try to simplify this. So the GOLD criteria looks at a number of different things. They want to reduce exacerbations, they want to improve symptoms, and they want to reduce airflow obstruction. So the first thing that they look for, and you can see all 3 things are on the slide, on the left side, the right side, and at the bottom, they want to improve airflow limitation. And the way that they grade that is what we've just talked about, the FEV1% predicted. If it's greater than 50% of predicted, it's stage 1 and 2. And if it's less than 50%, it's 3 and 4. And you can see the Roman numerals 1, 2, 3, and 4. Okay? On the other side of that, they have something called the exacerbation risk. And this should be intuitive, but the worse the obstruction, the more likely they are to get an exacerbation. So you see how many times per year have they had an exacerbation there on the right side of the screen. Is it 0, is it 1, or is it 2 or more? And you can see that those are actually kind of redundant. So what they've done this year in the new 2017 GOLD guidelines is they've just gotten rid of the airflow limitation part of it, okay? However, at the bottom, they have this CAT less than 10 or this MMRC of 0 to 1. This is looking at subjective dyspnea. So if you've got a patient, and you can go through these questionnaires, if you've got a patient with less subjective dyspnea, but they've had a lot of exacerbations, you could see there that that would be GOLD C for instance, okay? Or if they have a lot of shortness of breath and dyspnea, but they don't have a lot of exacerbations, well, that would be gold B, okay? This is not really intuitive. We're going to come back to this. The reason why, as you can see, they've made this is so that it can guide your treatment guidelines. Should this patient be on a LAMA, LABA, ICSI? How do we answer that question? We're going to come back to that. Okay, just be aware of this, the difference between the Roman numerals and the letters. Okay, so what's important to patients who have COPD? Doc, how long do I have to live? I've had many patients come and ask me that. And this is a very important tool to have because it can differentiate, as you can see here, on a 4-year survival, the difference of whether or not there's an 80% chance of them being around after 4 years or an 18% chance of them being around after 4 years. And I think that's a big enough spread that it's very useful. First of all, notice that we use a 4-year survival for COPD. That should be a ton of bricks hitting you right now. Because what's the time period that we use for non-small cell carcinoma mortality? It's 5-year survival. So COPD is on line with lung cancer in terms of survival. Now, obviously, the average survival for 5 years for lung cancer is about 20% or less. Here we've got 80%, so it's not as deadly, but we're using the same time period. So what BODE stands for, B-O-D-E, is it's an acronym. B standing for what? BMI. And actually, BMI of a lower BMI is worse than a higher BMI, okay? And then O stands for obstruction, so we're looking at the FEV1. D stands for dyspnea, which is the MMRC dyspnea scale, and I have it listed for you there. And E is the exercise capacity, so you can actually just walk your patients for 6 minutes in the office and mark off how many meters they've gone. You add up these points, and the higher the number of points, the worse the patient is going to do. And you can see here, it can be anywhere from 80 to 18%. So if you hit all of the points, that's not a good thing, but if you hit all of those points, so let's say you've got a patient with an FEV1 of less than 35% of predicted, you've got a patient who cannot walk more than 149 meters in 6 minutes, you've got a patient who really can't leave the house because they're so breathless, and they've got a body mass index of less than 21, they have a 18% 4-year survival. And you can tell them that so they can understand where they are. So BODE score is survival. And so keep those things in mind in terms of what is affecting survival. The worse the obstruction, the worse the survival. So that's COPD kind of in a nutshell in terms of diagnosis. Where I want to spend the rest of the talk is what do we do about this? And I've divided it into pharmacological and non-pharmacological interventions. Now, there are 2 items on this list that actually can improve survival. Guess what category they belong to, the pharmacological or the non-pharmacological? The non-pharmacological. Now, there's some claims that you'll see. We don't have strong evidence, but there are some claims, and we'll talk about that. So let's first talk about non-pharmacological, and the first one up there is smoking cessation. And of course, you could have a whole talk about smoking cessation. A whole hour, right? But this is one of the things that actually improves survival, no surprise. There is no other discussion worth having. I'll just say it straight out. I try to put it in proportion for my patients. This is really the cake. Everything else is just the icing on the cake, okay? It doesn't matter. It doesn't really matter if you have a LABA, LAMA, ICSI, PDE4 inhibitor. That's just kind of like rearranging the chairs on a sinking ship if you're not quitting smoking. That's the bottom line, okay? So if you have 5 minutes to spend with your patient, it's much better to spend that time telling them how they can quit smoking, period. The data is there. I mean, look at the FEV1 rate of decline. It's twice as much. 60 mLs versus 30. That's huge. It's you're running down that track to the cliff twice as fast if you're smoking. Forget about if the chairs in the train are, coated with leather or whatever. It doesn't matter. You're running off the tracks. Probably the best, we know that the best way of intervening for your patients is both counseling and medication. And to determine whether or not your patient has tobacco addiction or whether or not this is social, psychosocial, the question that I think cuts to it right away is this very simple question. You ask your patient, in the morning when you get up, how soon is your first cigarette? If it's within 10 to 15 minutes, these people, if they're having a cigarette in bed, that's a problem, okay? So that's a nicotine thing that you're going to have to deal with somehow, either nicotine replacement or Chantix or something like that. Okay, smoking cessation. I'm not going to belabor that, but it's worth talking. Vaccinations. That's important because these patients, COPD patients, die from exacerbations. I'm going to ask you this question, and all of you in here are good test takers because you all passed, got through medical school and residency and all those things. So you know how to take questions, right? So here's the question. If I have two patients admitted to the hospital, I have a guy with an MI and I have a guy with COPD exacerbation. Which one has the higher 30-day mortality? The COPD exacerbation, right? But if you had that on a test somewhere outside, you put the MI, right? Well, think about it. Go down to the ER. Where's the guy who's having the MI in the ER? Where is he? He's in the front room. And how many people does he have around him? He's got like 10 people around him, right? One's doing the EKG. The other one is reading the EKG. The other one's on the phone with the transfer center. They got the cardiologist on the phone, right? Where's the guy with the COPD exacerbation? Oh, he's in the back room somewhere. I don't know. Yeah, called the pulmonologist yet? Oh, yeah, I think we called it. He's somewhere. I don't know. People with COPD exacerbations die. They have a higher mortality rate. So if we can reduce exacerbations from COPD, we can save some lives. So reducing exacerbations through vaccines is important. Definitely the flu. We've got great data on flu vaccine and reduction of exacerbations. The data, until recently, was not really there for the polyvalent. Okay, it does reduce pneumonia. Some data. The one that I'm excited about is the Prevnar 13. That's exciting because you actually have a protein, it's conjugated, you have T cells, you've got memory cells. Maybe in a few years instead of Prevnar 13, one day we'll get to Prevnar 99, okay, or Prevnar 100 and something. Then that'll be amazing, okay? So vaccines. Supplemental oxygen. I think this is pretty simple to understand once you understand it, once you have it. For patients, not so much. Patients think that oxygen is the treatment for shortness of breath. That's the first thing that you have to dispel to them. This is what I explain to them. I say oxygen is like oil in the car. The only way you know if you have oil in the car is to pull the dipstick out and look at the dipstick. Those of you who have older cars, right? And we have newer cars now that don't do that. You cannot tell if you need You cannot tell if you need oil in your car by the way your car drives, unless it's too late. Okay? It seizes up. It's the same way it is with oxygen. The dipstick is the pulse oximeter or the ABG. So if the oxygen is low, we give oxygen. You could have great oxygen but still be short of breath. And you could also have low oxygen and not be short of breath. It doesn't matter if you're short of breath or not short of breath. It matters what the oxygen is. And so we have this threshold, this data. And the magic number there is 55. So if the PO2 is less than or equal to 55, you qualify for oxygen. That correlates with a SpO2 of 88. Now, if you have this thing called cor pulmonale, which you all know what that is, that's basically right heart failure, and there's many signs of cor pulmonale. There's enlarged liver, elevated JVP, lower extremity edema, loud P2, diastolic heave, right heart, all this kind of stuff, right? Rightward displacement of the PMI. So you could go through all of your differential diagnosis. If you've got cor pulmonale, we are more liberal with oxygen use because we're already starting to see signs of right heart failure. And so instead of 55, we move that to 59, which correlates with a SpO2 of 89. So I don't really care how old you are. I don't really care how short of breath you are. I care, but it doesn't really go into this equation. What goes into the equation of whether or not you get oxygen are these numbers. And this is what determines it. And this improves survival. So this is the other area that improves survival. So what is it? Smoking cessation, oxygen. Make sure you got those down on your COPD patients before you even start talking about bronchodilators. Those are the two major things, okay? Okay, pulmonary rehab. So in my mind, my picture, I think of Star Wars, the first movie where Luke Skywalker is in the, and I'm not a really big Star Wars fan, I'm not, but I just have this picture in my mind. Luke Skywalker's in the trash compactor, and everyone's getting trash compacted, and he's putting the poles up to try to, and someone, whatever, okay. That's what's happening to the COPD patient. Their life is closing in on them. It's because of this vicious cycle. They cannot do stuff because they're short of breath, and because they cannot do stuff, they become more short of breath, deconditioned, and they can do even less. So the way you push back on that is to do the exact opposite of what is getting you into that vicious cycle, which is to do exercise, which you would think is the last thing that these people would want to do. You're not hurting their lungs by having them exercise. You make sure that their heart can tolerate it, but pulmonary rehabilitation programs have been shown to improve exercise capacity, to improve quality of life, to decrease shortness of breath, decrease healthcare utilization. There's some evidence that it can reduce mortality, and it's indicated for 2 through 4. So in other words, all stages of COPD except for stage 1 indicated for pulmonary rehabilitation. Okay? I had a patient once who his whole goal in life was to golf. He just wanted to golf. And when his COPD got to the point where he could not even get out of his wheelchair into a golf cart and go on the course to golf, that's when his quality of life for him went down. So what pulmonary rehab was able to do was to get him from that position to get back into the golf cart. And so what's going on here? As you do more rehabilitation, biochemically what's going on is your mitochondria are being moved to the cell surface. There's more invaginations. There's better able to do work and make less CO2. That's important, right? Because now you cannot get rid of CO2 very well because your lungs have COPD. So if you can reduce the amount of CO2 that you're producing, you will be able to do more. And that's exactly what he was able to do, and he got back onto the golf course, and his quality of life went up. And that's really what we're all about, right? Okay. A couple of other approaches here other than pharmacological. Lung volume reduction surgery, big trial that was done at the VA that looked at this. Here's the bottom line. If you've got COPD and hyperexpansion, you're going to have flattened hemidiaphragms. As you know, the diaphragm is the major motor of respiration. Having a flattened hemidiaphragm to begin your respiratory breath is you're pretty much out of luck, right? So you cannot contract a flattened hemidiaphragm any more than it's already contracted. So all of the breathing is done up here with the accessory muscles. That's why it's so hard for a COPDer to breathe and comb their hair or screw in a light bulb. Because by doing that, you've just taken away their accessory muscles. They can't breathe. They get short of breath doing that. So the whole point of this was, if we could go in and remove some of that lung, especially a lung that's not working, we could maybe get back a rounded hemidiaphragm, so now they can take more breath. And so what they did was they did something called the National Emphysema Treatment Trial, where they went through and actually did this lung reduction surgery. So what did they find? Well, first of all, they took this group of people, they all went through pulmonary rehab, they made sure they did maximal therapy on them, and what they noticed was that the people who did worse were those that had really low DLCO. So what is a DLCO, remember again? It's basically the measurement of the cross-sectional surface area. So the low DLCOs were those that had very severe emphysema. So these people didn't do well going through this surgery, and the FEV ones that were really, really low didn't do well. So we don't want to have those go through it. But what they found was that those that had a heterogeneous distribution of COPD. So who are those? You guys have seen them before. The ones with the big blebs in the upper lobes. If we could go in and cut those out, we're taking out stuff that's not working anyway, and we're allowing the stuff that is working to re-expand, fill that space, and now you've got a nice rounded hemidiaphragm, and now you can breathe. I had a patient fortuitously, almost just like this. We don't do a lot of lung reduction surgery. It's just not done much because of this trial and things of that nature. But he had to have one done. And the reason why he had to have one done was he had a nice little bleb or bulla right in the left upper lobe. And because he had a long history of smoking, we're not going to get into this today, but this may be important information for you to know, is that we're supposed to do CT screening on these people, right? So if they've had a 30 to 40 pack year smoking history, it's been less than 15 years since they've smoked, and they could undergo surgery to remove a lung cancer, you should be doing annual low-dose CT screening on these patients. Well, that's exactly what I was doing, and lo and behold, he had a tumor that was growing in the middle of one of these bulla. So we did a biopsy, sure enough, non-small cell carcinoma. I think it was a squamous cell carcinoma. PET scan was completely clean, no metastasis, and we sent him for surgery. So they actually did surgery. They actually did lung reduction surgery on him, but not because it was lung reduction surgery, it was to cure his cancer. Lo and behold, after the surgery, he was breathing better than he was before he had the reduction surgery. So he was cured of cancer and breathing better. I think that was a great surgery for him. That's a study N of 1. But nevertheless. What about transplant? So when did these people go to transplant? So you don't want them going over the age of 65 generally because they don't do as well. And that's not just an arbitrary cutoff. We just know that these people don't do well. Here's the thing about lung transplant in general. It's not like liver transplant. It's not like kidney transplant, heart transplant. People with lung transplants just don't do as well. It's more of a quality of life issue. They did a study, probably about 10 years ago now, where they looked at the thing about the best indication for lung transplant you can possibly imagine. Not COPD, cystic fibrosis. These are young people who have a very bad lung and who are almost certainly going to die of some sort of pulmonary infection. And they did the study. They looked at survival benefit. These big transplant centers on the West Coast, UCLA, UC San Diego, that do these things. Guess what? No survival benefit. It stunned them. They were floored. So you can imagine if there's really no survival benefit for cystic fibrosis patients, what do you expect you're going to see in your 50, 60-year-olds who have COPD and they get a single lung transplant? We really don't see the survival benefit there, and so this is more of a quality of life issue. And you can see the criteria there. Let me show you a graph. This is the graph of people who actually have gotten a lung transplant, and those different colored lines are the different indications. So red is alpha-1 antitrypsin, blue is cystic fibrosis, which is the best one on the list, and then COPD is the green one, which is almost near the bottom. And they're all like basically parallel paths going in the same direction at the same rate. It really doesn't matter. Okay? This is not how a heart transplant survival curve looks. This is not how a liver transplant survival curve looks. So lung transplant is not a panacea. Okay? So that's non-pharmacological. Let's talk about pharmacological. And for this, we've got to go back to medical school a little bit here. There are two receptors in the bronchus. So the bronchus is the red circle. Two receptors. There's the beta-2 receptor, and then there's the M receptor, which is the muscarinic receptor. And so what the beta-2 receptor does when it's activated, as you know, is it causes bronchodilation. The muscarinic receptor, when it is activated, causes bronchoconstriction. And so what we want to do is we want to excite the beta-2 receptor, and we want to inhibit the muscarinic receptor. And you can see a list there of all of these different medications on either side. So beta agonists are albuterol, the salmeterol, the formoterol, the afimoterol, the indacaterol, the vilanterol, and the odaterol. So they all end in all. Let me just tell you, met a drug rep this week, came in. Do you know how many inhalers are coming out? Okay, literally, every day there's another inhaler coming out. There's like 3 or 4 companies, and they're taking that medicine and putting them together. So not the fact that there's just a new medicine, but there's a new combination of those medicines, right? It's like you're trying to break a code. I mean, literally, there's so many different combinations and permutations of inhalers that are coming out. What you're going to have to be able to do, you can no longer remember one type of medication. There are so many Me Too medications. You're going to have to actually pull off that medicine, look at it, look at the ingredients, and be able to tell, is this a LAMA, a LABA, or ICSI? And then based on that knowledge, be able to say, okay, where is that going to fit into your pharmacy, into your basically your workflow for COPD? Okay, so that's what I'm going to teach you today. You'll be able to look at any new medicine that they throw to you. You'll be able to figure it out. Because guess what? There isn't a new receptor. There's just a new medication for the same receptors. So it's going to be pretty easy, okay? On the other side, you got this bronchoconstriction, the anticholinergics, and they're ipratropium, tiotropium, aclidinium, and umeclidinium. And guess what they all end in? Right. Now, there is one exception to that. There's a new one out called glycopyrrolate. It's actually not that new. Glycopyrrolate is a anticholinergic medication that it does not end in IUM. So just be aware of that, okay? Glycopyrrolate. Okay, so let's talk about the beta agonists. They are short-acting, and you know albuterol. So the short-acting beta agonists are the rescue inhaler. This is the American Express of inhalers. Never leave home without it. Acuneb, ProAir, Proventil, Ventolin, they're all the same. People will swear that that one doesn't work, that's the one that I need, and they took it off the market. They're all the same. It's short-acting. It's designed to improve symptoms and lung function, as you know, and it's an ad-needed basis. So this is the one that they want to, you need to make sure they understand, this is the one that they want to use when they actually have symptoms. How many times do people go to the Advair or the Spiriva when they're having, no, that's not going to work. You need to go to the albuterol for quick relief. The other thing that I'll add here, for those of you who work in the inpatient, the beta agonists are probably the fastest thing tied with insulin and glucose if you want to get someone's potassium down. So be aware of that. If you have a patient in the office and you've given them, they're coming in wheezing, and you give them a nebulized treatment right there, or you send them over to pulmonary, and then they happen to go over to laboratory, and they come in and they've got a potassium of 3.0, don't think that that's because of the Lasix that you've given them with the spironolactone. That is a transient effect of the albuterol. So if I have a patient coming into the ER with a potassium of 6.0, the fastest thing that's going to get that potassium down is albuterol and insulin and glucose, okay? Of course, if you want to protect the heart, for those of you who work in the inpatient emergency side, nothing beats calcium in terms of stabilizing the myocardium. But that's not really changing potassium. All right, so now that was a short-acting beta agonist. Let's talk about the long-acting beta agonists. Salmeterol, formoterol, afimoterol, these OLs. And this goes back some time. The TORCH trial looked at this. And they found that in COPD, it did not increase mortality, but it decreased exacerbation rates, improved lung function, quality of life. They had to do an arrhythmia trial because the concern was that here you're doing long-acting beta agonist all the time. Is this going to increase tachycardia, tachyarrhythmias? The good news is when they looked at a respective review of over 76,000 patients, they did not see that. So that's good. So beta agonists. Now, there is a black box warning for long-acting beta agonists, but not in COPD. What's the diagnosis that it's a black box warning for? Asthma, okay? So make sure you understand that. You will have patients that come into you, and they are on this inhaler for COPD, or they have a beta agonist, and you'll see it on the commercial. They will say, warning, black box warning, don't use this if you've got asthma. They will only have that black box warning if this long-acting beta agonist is not paired with an inhaled corticosteroid. So let me review this. If you've got asthma, the only way you can take a long-acting beta agonist is if it is paired with a inhaled corticosteroid. Can you take a long-acting beta agonist in COPD without an inhaled corticosteroid? The answer is yes. But they will put a warning and say, don't use this by itself without an inhaled corticosteroid if you have asthma. You have to understand the difference between those two. Which brings up an interesting question. What happens if you've had asthma your whole life and now you have COPD? And that's kind of the overlap thing, and that's controversial. We'll talk about how I deal with that. Muscarinic antagonists. The first one out, as you know, was ipratropium bromide. I remember working at the county hospital. It was our favorite way of getting inhaled anticholinergics into people was Combivent, right? Because every time they went to take a whiff of their rescue inhaler, we were sneaking the anticholinergic in there. That's the only way they would take it. Very non-compliant. Right? It's also 4 times a day, right? Who's going to take an inhaler 4 times a day? Good news. Spiriva comes out 10 years ago, and now you've got a once-a-day anticholinergic medication. And so all of the trials were done on Spiriva, tiotropium, and what did it show? Let's talk about that. The long-acting. So we had tiotropium, now we have aclidinium. The Uplift study was done, and again, we were concerned about safety issues because we're We're blocking the vagus nerve, increasing the heart rate. Could there be tachyarrhythmias? The answer was no. So then they started to say, well, what's better, LAMA or LABA? What they should have been asking was, what's better, single therapy or dual therapy? And now we're sort of going down the same road that we were talking about with hypertension, is if one medicine's not working, can we add another one? And which one do we add? And so we saw that there was really little difference between LABA and LAMA, and the big thing was LAMA plus LABA. So LAMA and LABA together, the meta-analysis showed that it was improved, and we have good data going back many years on this. Okay? So here's probably the, and I love it, they spend so many millions of dollars on these studies, and these are the statements that they get out of it. So check this statement out. In a patient with GOLD stage 2 through 4 COPD, whose symptoms are not well controlled with a single long-acting bronchodilator, the addition of a second class of long-acting bronchodilator may provide additional benefits. Cha-ching! Thank you for that. So yeah, this is obviously, we knew this was going to happen. But yeah, combination versus monotherapy. And so what do you see now? You see the addition of these LAMA-LABAs. Right? And if you don't understand what LAMA-LABA, now you know what a LAMA-LABA is. So what are the new LAMA-LABAs, right? There's Anoro, Ellipta, there's Stialto, there's another one that just came out this week with glycopyrrolate, and I can't even remember the name of that one. There's so many of them, but you will know. So then we have this interesting topic of the inhaled corticosteroid. What was the big revolutionary inhaler back in the early 2000s that came out for COPD? The purple disc. And what were the components of the purple disc? It was a LABA and a steroid, exactly. So we were giving out, and people have been on this medicine for years and years and years and years and years. Elderly people on inhaled corticosteroids because we found that it worked. And it was probably the LABA doing most of the heavy lifting. So what do we see? So inhaled corticosteroids have been around for years and years, right? Fluticasone, flunisolide, et cetera, et cetera. The problem is that it can cause osteoporosis. It actually increases the risk of pneumonia, believe it or not. Skin thinning, cataracts. It does decrease exacerbations. It does slow the progression of respiratory symptoms. But in terms of the asthma COPD continuum, COPD doesn't have the inflammation. It does have some inflammation, but it doesn't have the inflammation that asthma has. And so should we be using the inhaled corticosteroid here as first line in a COPD patient who's elderly and at risk for osteoporosis, who's at risk for getting pneumonia? Where in the algorithm should inhaled corticosteroids be? And then couple that thought with how many people out there are on a LAMA-ICSI combination. And now you can kind of see where we should be going with COPD therapy. So they looked at the TORCH trial. This goes back and really is the establishment for why Advair was such a great drug. It was because, it had great data for it. And that was the fluticasone salmeterol. And so you can see the INSPIRE study that was published back in 2008, 2010. So this is decades old information. And then finally, of course, you've got an ICSI, you've got a LAMA and a LABA. So the question is triple therapy, right? And there's a certain drug company that's come out with a medication that plays off of the fact that there are 3 medicines in one, and it's once a day, because they have a patent on the only once a day inhaled corticosteroid. And you can actually get all 3 medicines now in one inhalation. And that's just come out. So, and by the way, I have no stocks. I don't speak for any of the inhaler companies. So I've got no dog in the race, okay? So what do you think? Triple therapy better than dual therapy? Yeah, if you need it. So how do you know how high you need to go and what order do you go in? So here is the thing that I think you should take home. This is the slide. This is the money slide. Asthma and COPD are at different ends. And let's go through what these mean. So the SABA is the short-acting beta agonist. Everybody should have albuterol. You got an asthmatic or a COPD, or it doesn't matter. They get albuterol. They get ProAir, Ventolin, whatever it's going to be. The way I look at, and the way the guidelines look at, how well this patient is controlled is you ask them. This question should be documented. How often are you using your rescue inhaler? If the answer is 2 or less times per week, they're controlled. And what you don't add into that equation is whether or not they're using it before they exercise. We do not count that against them. They use it before they exercise, that's great, that's a freebie. But if they're actually getting to an exacerbation where they have to use their albuterol inhaler, that is a rescue inhalation. 3 or more times, it probably is a good idea to escalate therapy. And what do we do in COPD? We start with the LAMA, okay, so the long-acting muscarinic antagonist. Then we move to a LABA. Yes, we're actually using a LABA here without inhaled corticosteroid. That is okay to do in COPD. And then finally, if that doesn't work, then we go to the inhaled corticosteroid. Okay? So that is the order that we should be escalating therapy in. So as a result of that, you can see the popular medications now for COPD is not Advair or Symbicort, all which are indicated for COPD, by the way. Okay? The ones that now are popular because of these gold guidelines are Stiolto, Anoro. There's other ones that are coming out. Basically, it's the LAMA-LABA combination. And this is where this is coming from, LAMA-LABA's combination. You will not see a monotherapy LABA FDA approved anymore for asthma. They will always come out with an inhaled corticosteroid. However, you can get LABA monotherapy for COPD, FDA approved. Okay? So that's why you're seeing the things that you're seeing. It's because of this thing. So what do you see here? You see all sorts of different ones. Now what you can do is you can just pick up the inhaler, look at it, and say, what type of an inhaler is this? A LAMA, LABA, or ICSI? Or is it a combination of what? And you'll know exactly where this needs to go. You'll know exactly what medicine this is used for. Okay? You will be very smart. So those are the inhalers. So what else do we have up our sleeve? I know we're getting about 8 minutes here before 9 before the break, so let's move quickly. And you can see here that, yes, this is almost 2018, and yes, I do have Theophylline on the list. So you have to understand that as a COPD specialist, as a pulmonologist, sometimes I see patients who are on all 3 medications, and they still have shortness of breath. They are at the end of their breathing career, okay, of their life. So the question is what do I do? I've got to treat them somehow. And Theophylline does have its role, but it's not one of the ones that I'm going with first. The biggest issue with Theophylline is drug interaction. And let me give you a little illustration of that. Let's say you've got a patient who's been smoking 4 years. I mean, not for 4 years, for years, okay? And they're smoking. And you know what tobacco smoke does is it revs up the P450 system. It's probably one of the most potent inducers of the P450 system that we have, other than rifampin. So, as it turns out, Theophylline is metabolized by the P450 system. So imagine a patient who's been smoking, you've got them on Theophylline, you're monitoring, they're doing great, and then they quit smoking. They finally listen to you, and what happens? They get Theophylline toxic because their P450 system slows down, the Theophylline levels rise. So just something as simple as getting them to quit smoking could make them go Theophylline toxic. So make sure that you're aware of that, okay? PDE4 inhibitors. So I like to say that PDE4 inhibitors to COPD are like statins to myocardial infarction. You take people who have risk of getting a myocardial infarction and you put them on a pill every single day that doesn't make them feel any better, but it reduces the risk of some really bad event. That's exactly what a PDE4 inhibitor does. A PDE4 inhibitor is a pill that they take every day. It doesn't make them breathe any better, but hopefully it reduces the risk of them getting a COPD exacerbation. The guy who's in the back room that no one's called the pulmonologist on, who's going to be intubated very shortly, right? If we can prevent that, we can prevent COPD deaths. It's about a 40% mortality. So these PDE4 inhibitors, there's only one on the market. It's rofimilast or Daliresp. And the early data showed that there was a reduction in inflammatory markers. Is it an anti-inflammatory? I can't say that it's an anti-inflammatory, but we saw that it reduced inflammation. Let's put it that way. And if you put people on this medication for a year, it was able to decrease the rate of exacerbations by a significant amount, to the point where you could treat 4 to 5 people with this and reduce exacerbation by one event. So about a 17% reduction. So the number needed to treat is something that you need to know. The lower the number, the more powerful the effect. So aspirin, for instance, is 30. And we give aspirin like it's a no-brainer, right? So NNT for this is 4 to 5. To give you an idea, how many people jumping out of a plane would I need to give a parachute to save one life? 1, right? So the number needed to treat for a parachute is 1. Pretty darn effective therapy, okay? It's probably actually 1.00001, right? Because I mean, we have history of people jumping out of planes and surviving, and sometimes people jump out of planes and even with a parachute, they don't survive. So it's probably 0.0001. But number 1, NNT, very, very powerful. But you got to use it every day. So what are the big side effects of DALI-RESP? Number 1, weight loss. Number 2, a little bit more loose stools. So sometimes I'm explaining this to the COPD patient, and the wife or the husband puts their hand up and says, "Can I get on that too?" No, can't get on that. Oh, but here's the thing. When they looked at the first studies in the subgroup analysis, they found that the people who had the severe type of COPD, so less than 50% are predicted, GOLDS 3 and 4. So a FEV1 of less than 50% are predicted. And those who had an exacerbation within the last year were the ones that benefited. Okay? So remember that when we get to the question. PDE4 inhibitors work best in those who have 3 and 4 and have had an exacerbation within the last 12 months. What about others? Steroids? Please don't put your patients on long-term prednisone. It just gives them osteoporosis and erodes the lining of their stomach and really doesn't help. Mucoactive agents, not helpful. Here's the new one too, azithromycin. So let's say your patient can't tolerate DALI-RESP. Azithromycin is not FDA approved, but there is good evidence. This antibiotic has anti-inflammatory characteristics. There's good evidence that if you put your patient on 250 milligrams of azithromycin 3 times a week, not every day, 3 times a week, that can reduce exacerbations in your COPD patients. So think about this in your blue bloaters, in your patients who are in the hospital. Yes, they did find a higher incidence of macrolide resistance, bacteria in the oropharyngeal cavity, but really no pneumonias that they got clinically with this type of resistant bacteria. So maybe just a clinical microbiological side effect, but not a clinical side effect to this. The other caution that I would give is make sure you've got a QTC, okay, the QTC time on your patient before starting this, because azithromycin does prolong the QT. And if this patient is on Sotalol or some other, like diflucan or some other medication that can prolong it, you don't want to give them these VTAC events. So that's the state-of-the-art approach to a COPD patient today. So let's go over the questions and see if you have learned something, okay? 100% is what I'm going for here. All of the following are true except question number 1. FEV1 divided by FVC ratio of less than 0.7 defines the presence of COPD. The severity of COPD is determined by the FEV1% predicted. A Bode score of 10, the maximum, is at 18% 4-year survival. Alpha-1 antitrypsin deficiency is seen only in males because it is X-linked, or the majority of COPD is caused by smoking. So all of these are correct. Which one of these is the incorrect statement? Okay, so it's not 100%, but it's certainly on its way to going to 100%, and that is correct. So alpha-1 antitrypsin is an autosomal recessive gene that causes COPD early in life. So think about this in your 40 or 50-year-old, not who has COPD because they've never smoked, but it's getting COPD much earlier in life because they smoke, okay? And the severity of COPD is actually caused, or actually is graded by the percent FEV1 predicted. All right, next question. Which of the following patients would benefit from supplemental oxygen? Is it the 55-year-old male with severe shortness of breath and a resting SpO2 of 92%? Or is it the 65-year-old female with a resting PO2 of 58 and with bilateral lower extremity edema? Or is it the 75-year-old male with severe shortness of breath and a PaO2 of 58? Or is it a 68-year-old female with a resting SpO2 of 90? Or is it a 70-year-old male with severe shortness of breath and a resting SpO2 of 92% with bilateral lower extremity edema? Which one gets the oxygen tank? Okay, so quickly we can see here that B is winning out, and that is correct, because why? We have bilateral lower extremity edema, which means we have cor pulmonale, which means we use the more liberal cutoff, which is at 59. And this patient is 1 millimeter of mercury below that at 58. The other ones don't qualify for either the reason of it's not less than 55, or if it is and less than 59, or its corresponding saturation, they don't have cor pulmonale. So those are the two things. All right. Pulmonary rehab is indicated for what type of patients with shortness of breath? Is it all of them? A, 2 through 4B, 3 through 4C, or 4 only D? Which one? And you can quickly see here that that 2 through 4 is winning out, and that is correct. So it's indicated for all types except for type 1. Excellent. Okay, my favorite question. What is the appropriate order to escalate therapy in severe COPD patients? And we'll talk Klingon here for a little bit. A, is it LAMA, ICSI, LABA? ICSI, LABA, LAMA, LABA, ICSI, LAMA? Sorry, LABA. Is it LAMA, LABA, ICSI, or ICSI, LAMA, LABA? Which is the way that we escalate therapy? All right, you guys are nailing it. Sort of. So we don't want to start with the inhaled corticosteroid, because that's going to cause problems, right? Excellent. All right, you guys are getting it. So it's LAMA, LABA, ICSI. I don't even know if ICSI is a real abbreviation. Question number 5. Which patient would benefit from a PDE4 inhibitor? Is it A, a 55-year-old male with FEV1 of 20% are predicted and no serious exacerbations in the last 5 years? Is it a 65-year-old female with an FEV1 of 60% are predicted and a recent hospitalization 4 months ago? Is it a 75 with 45 and 10 months ago? Or is it somebody with 40% 2 years ago? I'll just focus on the appropriate information there. So which one gets the... All right, so we're looking for gold stage 3-4, which would be a FEV1 of less than 50%, and a flare less than 12 months ago. And I can see that C is winning. And with that, I am done. Thank you very much.
Thank you, Roger.